Thank you. It's my great honor to co-host this interview with Stephen Chen, our chairman. And also we are very glad to be here to talking about multidisciplinary teams, MDT, how help optimize treatment strategy for HCC, especially now. And now we have talent series of the study, which will include talent top. That means address the benefit of conversion surgery plus maintenance therapy with systemic therapy alone. And also we have talent taste, and that second study explores the synergy of combined taste with highly effective atezolizumab and bevacizumab regimen in intermediate and advanced HCC. And also we have talent true. That's a real-world study retrospective, which means show how can we get the conversion surgery after the combined therapy. So all of this study needs multidisciplinary collaboration. This is why we are here. So it's my great pleasure to introduce our panelists today. From Stephen first, Professor Stephen Chen, President-elect of the International Liver Cancer Association, and from Chinese University of Hong Kong Medical School, and Professor Maria Rick, Head of the Hepatic Oncology, BCLC, a hospital clinical de Barcelona, and IDFBs and University of Barcelona, and Professor Tianqiang Song, Executive Director of the Hepatobiliary and Pancreatic Cancer Center at the Tianjin Medical University Cancer Institute and Hospital. And we have Professor Alex Tang, Head of the Vascular and Interventional Radiology at the Subhan Jama Medical Center, Malaysia. So first of all, we have a question for all panelists. In clinical practice, how do you and your multidisciplinary teams carry out diagnostic and treatment actions to help HCC patients? Please share your experience from you.
Maybe let me start first. I think the diagnosis is quite straightforward. Most of the time is made by our surgical colleagues or hepatologist colleagues. Of course, there are occasionally some patients with borderline features that they may bring to the MDT board to discuss further investigations. For the treatment, of course, we have a lot of patients. We cannot put every single patient to the MDT, but we do have a weekly joint clinic between the surgeons, oncologists, and the radiologists. We also have a tumor board kind of discussion every month. So we have these two modalities or platform to discuss usually those more complicated patients or patients with different responses to the previous treatment. But my observation is that recently we get more and more cases to discuss, probably because there are more variety of the patient, especially more downstaging or the planning of the sequence of the treatment.
Great. So, Maria?
So in our unit in the BCLC, we usually discuss the patient for diagnosis if there are any doubts. Cirrhotic patients are for non-invasive criteria. The non-cirrhotic patient, we perform biopsy. And also for those patients who have other cancers, we also perform the biopsy. I agree with you that is not the main problem. The majority of the patients that are discussing in the tumor board are for clinical decision making. Indeed, we have a study for the last 4 years, and 45% of the patients are presented with that aim. In our hospital, we have the unit. That means 7 departments are working together for a transversal aim, that is liver cancer management. So the discussion is at 2 levels, as you are doing here, one-to-one, one specialty, but then we move to the tumor board. I agree with you that it's impossible to present all patients. We usually mention that we have the patient with new treatment or new diagnosis, but we only discuss those who have doubts that we need to have more than one discipline there.
Okay, so you have 7 departments working together.
Yes, we are 43 members in the BCLC, and there are all the disciplines, including the nurses and also the administrative support, because for us it's very important the patient journey, not only delivery the treatment, also the hospital work evidence-based and value-based care. Means try to add value in the procedure of the treatment.
Thank you. How about you?
And in my center, and the MDT team was established in 2011, founded by me, and they consist of the 6 department and the surgeon, radiologist, oncologist, intervention oncologist, and the radiological oncologist, and ultrasound doctor. So every week, every Thursday afternoon, we'll meet together to discuss the complicated cases. Not every cases, because the patient admitted in the hospital should be in the staging first. If BCLC-A or CNLC very early stage, so maybe go to the surgery directly. So there's no necessary to discuss. So most of them in BCLC-C or some the recurrence HCC. So we refer to the MDT meeting to discuss and to determine so which department should do first and the second department do next. And we already run 14 years.
Thank you, Dr. Song, 40 years. How about you?
Thank you. Like any other tertiary center, we have our MDT teams. Essentially, ours in Malaysia is a bit different. In the oncology side, we have the field of clinical oncology. We take care of the radiation and medical oncology. So we have 5 members. And like any other center, those complicated cases, those need special attention, intermediate or advanced diseases, will be presented in the MDT team. And decision is to made to proceed with surgery combination. We do a lot of combination tests and the systemic treatment, and frequently we also add in the radiation therapy in the group. So it has been running quite well for the last few years. I think so far we have a lot of success stories.
Thank you. So I'm also the panelist, so I can talk something about my own experience, because I'm in since 2022. I established a liver cancer program in a hospital. First, we have MDT clinic. That means a patient came to my hospital. All of the new liver cancer patients, they will see 5 doctors at the same time, from Monday to Friday afternoon, and then different people there. But at least 5 to 6 departments. So that's clinic. Then we decide, and on site maybe, and you'll go to surgery, go to and intervention oncology. That's the first one. And every Tuesday morning, we have an MDT in discussion for all liver cancer patients. And that is for all in-hospitalized patients. Discuss very detailed thing. Even pathologists will join us. So even TCM, Traditional Chinese Medicine, they will join us. So we have 10 departments. You join together talking about what's the best choice for the patient. Maybe you go to the intervention oncology first, then back to surgery, and maybe you go to oncology first, and let's wait. It's possible for converging other things. So that's the second. And also the third thing, after surgery or other treatment, we have mortality and morbidity conference for all the patients with some unexpected thing happen. We'll go back to see, wow, what happened? Is it wrong for diagnosis or the other thing? And then the fourth thing, every 3 months, we will have a conference online with Harvard, that our partner from Mass General Brigham and Dana-Farber Cancer Institute. We will select maybe 3 of them, share that with them to see what's the best for them. So that's our now system for the MDT. And also the 5 is all of us, the people, not just working for clinical work, we share all the resources, especially for the student. And we postgraduate student, that means we have a strong team from clinical work to the education and to the research. This is our, just for several years. Okay, so I think we will go to the next question that's more specific about, as Alex, you just mentioned, talentase. Talentase is a study established itself as a novel treatment strategy for intermediate and advanced HCC. It's part of a new option for HCC reversion therapy. So what is the value of talentase for MDT in optimized patient treatment? Maybe it's for all panelists. I think from Dr. Sun, you first.
And talentase, MELD1, and LIPS 012, I think all these in the clinical trial showed and the combination will have the more PFS than the single TACE. So, but for our surgeon, but we can see if we use the RECIST criteria and the overall response rate is very high, they maybe give the surgeon the chance to cure this part patient. So I think maybe combination of systemic therapy plus and intervention therapy maybe is a good choice for conventional therapy. Maybe better than systemic therapy alone or intervention therapy alone. So I think maybe this part of clinical trial, maybe OS is not the primary endpoint in future. And it's also very difficult to get the OS and the significant difference. So maybe, and if we got the chance to do the radical resection, maybe the OS can see the significant difference.
I get your point. That's something I prefer to. Either is maybe we can get some surgery for those patients very down stage, but we need try. We need to some clinical trial for that. And Alex, I know TACE is your favorite. What do you think? You want TACE everyone.
Actually, to me, it was a blessing. We know that when we do TACE, there are areas which is not optimally covered by the TACE itself, could be addressed with a systemic treatment, both either TKI or anti-VEGF, and of course with the additional ICI that actually optimized. So our landscape in TACE has changed. It become a routine for those cases more than 3 cm, especially multiple. We do TACE with systemic treatment, and it has actually have very good clinical result. Your study actually bring a lot of good news to the practice, because a lot of oncologists do not agree or perhaps understand until this real-life data, your talent TACE, we one of them, we can show it to them. Let's look, we have the clinical benefit of doing this together. So from 2020 to 2025, before this come out, we saw that the oncologists, TACE doesn't work, so everything systemic. But I always remind them that don't forget 70% non-responder. So you have to address that 70%. So with this paper, we can tell them that you need to put TACE back into the practice. That's why in the last 1 year, my oncologists are more kind of like accommodating, or perhaps agree that we should put two together to achieve a good result. I think you have done a good job.
Thank you. So that's why we need everyone. Everyone contributes. So very short question, as an interventional oncologist, TACE first or systemic therapy first in your combination therapy?
I think it's very patient dependent. If you have a huge tumor like those presented this morning, I would say systemic treatment first. I fully agree, 4 cycles is a good time, 4 cycles. We have cases after 4 cycles, it shows remarkably come like partial response, then we go into TACE. You have an advantage of less tumor burden, less side effect, less post-embolization syndrome. Of course, if you have spatial equipment like angio-CT, we have angio-CT. That angio-CT will actually help us to identify where are the residual viable tumor. And using the what we call angiographic Google Maps software, we can actually very selectively take care of the random very well. And definitely you will see the result. And the other hand is that post-treatment progression, right? I think we have quite good experience with cases after this systemic treatment, then that they have a very good initial response, then the AFP start to search. We go in selectively, we know where are the tumor, and then we can take care of them. So we have to work hand by hand. Support each other. And like a chair, you have 4 legs. You can't do without one.
Okay, thank you. And for Maria, for the talent TACE study.
This is a very complex question because now we have, as you mentioned, 3 phase 3 trials, all with progression-free survival. One is negative, LEAP-012. Other have immature survival, that is talent TACE, and the other one we are unknown. So at the end, the idea of the new version of the BCLC is, okay, what is the evidence to support that? It's a phase 3 clinical trial, but based in progression-free survival. That means, what is the goal? The goal is delay progression. If the answer is okay, in this region that you have the data, maybe the decision could be completely different, as we have in Barcelona, that the regulatory agencies only approve based on overall survival. So my point here is to reinforce this idea of the rational interpretation of the data, and the complexity and cues is this: uncertainty, the prognosis; subjectivity, the interpretation that we have for the data; and also the emotion, because it's based on my patients, it's only my past experience, but I don't have others. So at this day, we have to take the decision. In Barcelona today, we can, if the patient is candidate for TACE, we start with TACE and wait to develop progression. If the patient is beyond TACE, we start with systemic therapy, and then we can discuss. But we also have the ABC trial that you already know, that is TACE versus systemic therapy, and we propose the trial. I would like another thing that is also important, because now we are thinking about conversion therapy or what we will do next, but today in this tumor board we have to take the decision.
Yes.
For my understanding, the decision is systemic therapy with the aim of going to, and this is the temporal decision that we need also to be training to discuss together.
Yeah.
Practice is a bit different. Pre-TACE systemic treatment has advantage of the vascularity modulation. We want to reduce the vascularity, especially for lenvatinib. There is dysfunction of normalizations of the tumor fetus. All this has advantage for TACE. On the other hand, we have also cases sometimes, for instance, I have a patient that have a 6-7 cm tumor, right? We went in, it works very well. But we know 40% of them we have recurrent somewhere else in next 3 months to 6 months. So we have actually evolved to extend that if I TACE lesion, if I have more than 3 lesions, or I have a tumor more than 5, routinely I will request my oncologist, can you please kindly start a systemic treatment because of this 40%, right? We have seen enough patients whom we downsize it, convert them to a surgical candidate. Then the surgeon operate the patient, but they didn't send the patient back. 6 months later, multiple lesion comes up. So that 40% always in our mind. You have to take care of them. You have to continue with some systemic treatment to maintain your clinical success.
Thank you. So now, finally, Chairman, what do you think about
I think all good points have been mentioned by our excellent panels. Maybe I just add one point. Is in the past or during the EMERALD-1 study, people are a bit concerned about the use of BAF around the TACE, probably because of bleeding or sometimes the damage of the hepatic function. But from the TALENT TACE, we know that actually quite safe to use atezo-BAF around the TACE period. Of course, maintenance period, the experience is very similar to what we have used as an advanced setting. I think this is one point that I would like to add. So about my keynote practice, I think as I already expressed, it would definitely be one of the choice when we discuss with our patient, because it's backed up by some phase 3 data. But probably the lack of overall survival, we don't know yet. But if there's really no overall survival benefit, it means that we cannot offer to every single patient. You need to discuss the risk, the lack of OS benefit, but yet higher response rate and the PFS. All these will count when we discuss the treatment with our patient and also in the tumor board.
At this moment that we don't have the overall survival, will you promote the use of the combination at this moment, or do you consider the patient is for TACE or systemic state with TACE and then give systemic or in combination?
Well, for me, if the systemic treatment is ongoing very well, I would recommend to continue. Put TACE as on demand. If the systemic treatment shows that there is a slowdown of the response, or perhaps the second spike of the tumor marker, or perhaps progression, then TACE will come in to help to control the tumor.
Okay, so I think briefly for the TALENT TACE, now we have 2 points, it's good. maybe it's safe, and also the ORR could reach 49%. 49%. It's much higher. Maybe have to downstaging, but we don't have a positive OS results. So maybe we wait on, at least we provide another option for the patient. So it's for the tendencies. So I will hand over the next question for Stephen.
Okay, so moving to the third question for discussion. The first question I would like to address to Dr. Song. The TalentTop study latest findings were presented just in the 2025, the ILCA meetings and also the ESMO meeting. So what were the key takeaways from this update?
Yes, we just discussed TalentTop and confirm this is very safe and effective and the treatment option for conventional therapy. And also answered another question. And if the patient received the resection part, maybe have the better prognosis than the continuous systemic therapy and arm. So maybe by now the OS and the data is immature. But from the two curve, you can see they separate very, yes. So maybe in future, I think, and such as EMOD1, such as Talented, such as and LEAP 012, because this clinical trial, not a real clinical practice. So maybe in real clinical practice, this part patient, maybe we convert to surgery. So I think TalentTop tell the result, maybe give some and the instruction for the future strategy making.
Thank you, Dr. Song. Then the next questions to follow is to the panels. So for those patients who have really completed the conversion surgery, so what is your surveillance strategy? Will you do the same for ordinary surgical patients, or you did more like an advanced setting? And also another question that we may also discuss is, will you maintain the preoperative regimen? So after the conversion surgery, what sort of treatment you will give? The same regimen, different regimens? Maybe this time I go back to my previous chairman, Professor Quantas.
Thank you.
What's your thought?
I will continue the same regimen first. And also, our MDT will have very good collaboration with our clinical trial unit. And they will have 5 or 6 people working with us. They will follow up all the patients, each of them.
What's the follow-up frequency?
Oh, 3
The
to same.
Same as a surgical
same
patient?
Same as a surgical patient. And we'll give them a call 3 or 4 months and after they discharge, and they will call them back at least and twice a year. And for all of them, they will come back. And also at the clinic, we will gather all the information, including PBMC, for all of them.
How about Maria in center?
In Barcelona, we don't do conversion therapy routinely. In select patients, sometimes the patient maybe have to stop the treatment due to adverse events and so on, and we could consider resection. But until having more data, is patient by patient and it's not routinely. And we continue with systemic therapy until develop progression, or if the patient develop adverse events. In a specific clinical trials, there's a cutoff. Now there are clinical trials usually consider 1 year after achieve complete response to stop the treatment. This is under debate, and I believe that the trials will give us the answer, because no one have the capacity to say if it's 1 year better than 1.5 or less.
Fair. How about you?
Interestingly, for those patients, right, especially those respond very well to the treatment, you can see the tumor shrink, but it doesn't shrink fully, or perhaps it shrink to very small, like 8 cm shrink to about 1 or 3 cm, 2 cm. We have seen enough cases that when the AFP start to spike, there will be this marginal recurrence around the tumor scar, and this acts as a recurrence. So we also see the other group patient where the tumor like 14 cm shrunk to 8 cm, and your MRI, CT scan show nice tumor scar avascularity. We bring them back to the angio using a CT hepatic arteriography, right? The advantage of CT hepatic arteriography, we park the catheter in the hepatic artery, then we do a CTA as compared with the usual intravenous CT. The concentration in the hepatic artery is 10 times higher. Then we start to see this intratumoral recurrence of small nodules. So if you ask me, any tumor more than 7 cm, once you have achieved conversion, operation will offer a better clinical outcome in terms of preventing secondary recurrence, which invariably it will come, right? Matter 1 year, 2 years, or 6 months. As for those post-surgery, right, because we know 40% recurrent in the opposite liver, our practice, in my personal practice, is that the first 3 months, we check out the tumor marker and MRI with the liver-specific contrast after 3 months. Then another 3 months, after that every 6 months. Then we usually ask them to check the alpha-fetoprotein or PICA2, whichever is raised, every 2 to 3 months. That will actually help us to pick out a tumor very early. Unfortunately, a lot of them are cirrhotic. Ultrasound doesn't really help much, right?
Okay, thank you. Then we move to the next questions. Following the TalentTop study, we know there's also a TalentTrue study. So what's the background and rationale behind this study? Maybe I could ask the PI, Professor Kwan, to introduce the key findings of this study again.
In fact, it's 3 years ago we have a launch study, and to our surprise, we used to think it just compares the OS and the TACE plus lymphadenum against the lymphadenum, but to our surprise, and 16% of our patients, these all are unresectable with PBTT, blah, blah, and they can receive curative resection. And also now, 3 years plus, 90% of these patients still remain tumor-free. That's to our surprise, I don't know. So that at least at all 20% of the patient can benefit from this so-called conversion. Conversion means local therapy plus systemic therapy. So that's why we tried TACE plus atezolizumab plus bevacizumab. I think it's working. And then we retrospectively collected the data from 5 centers in China. I want to see how about that? We want to learn in the real world. It's not prospective design, it's retrospective. 30 patients from the 111 patients, 30 of them, they can get resection. So I do think, and also 15 of them, PCR, pathology, complete response. So at least I think is 30% of these patients can have the chance for those unresected patients, and they get the chance to be resected. No, of course, the survival benefit much longer than those without resection. So let me see, that's why I like that figure in the ESO guidelines in 2024. Our aim to maximize the therapeutic impact of our curative resection is to, for the small burden tumor, directly go to the surgery, ablation, SBRT. For the heavy burden, maybe downstaging, and give this patient maybe 30%, they have another chance. And in the big picture, we can definitely increase the overall survival of the whole population. That's what I think.
Very exciting. So we finally move to the final question, and this is for the whole panel to discuss. Feel free to jam in or ask each other questions. Now we have 3 studies: TalentTop, TalentTaste, and TalentTrue studies. How would these influence your MDT decision making? Will you consider it, or 1 or 2 studies, or you don't bother at all? I think we would like to hear your opinions or comments. And of course, as panelists as well, I will make the final comment. Maybe this time, Maria, you first.
Unfortunately, I don't live in China, so all these trials.
Oh, unfortunately.
Unfortunately.
Just kidding.
So I can use this data because the population that was tested in this trial was not the patient that we usually treat. So at this moment it's interesting, but I can use or influence my clinical practice. However, if I have a patient that we can discuss and we don't have the chance to do in a second line or in a specific time, I can say these are data to support the safety and the capacity to develop this response. So again, we come back to the cues. We have to decide based on a specific patient. Evidence, there's evidence for progression-free survival, that's not that. And then it's more than we have 1 year ago. It's a good news. But unfortunately, I'm not here.
Well, you send the patient to China.
Maybe.
Yes?
Well, certainly, when both the paper embraced 150 and APA consensus work guideline came out in 2020, we see a major drop in the volume of the taste, and we actually see a dark future for taste. But with this, I think there's
A reanimation.
yes. We see more hope in terms of better tumor control, and hopefully your OS really proved that it have a survival benefit. But in the clinical front, from what we have done, definitely we see the patient enjoy the benefit of combination therapy, right? And our longest survival is 8 years in BCLC with massive VP4 tumor infiltration.
How many patients?
So far, we have about 5 patients survive of 6 to 8 years. On the other hand, for those very big tumor, our recommendation is that to have it resected if you can, because the two things, we see some of them develop secondary infection of the tumor scar or biroma formation. And when the biroma formation set in, the surgeon is very reluctant to operate because of dense adhesion. So that comes to a time that nowadays we recommend curative resection ASAP when the patient is fit.
And in my center, we usually divided the unresectable patient in 2 parts. One we call the potential unresectable. The other is unresectable. So potential unresectable, some is the technical unresectable or the oncological unacceptable. So if he only one factor, so maybe this part patient we would like to combination intervention therapy with systemic therapy, and if there's any chance to convert to the radical resection. But if the patient has both of these factors, so I think this is unresectable. So we prefer systemic therapy first, and then step by step add the intervention therapy or local treatment, and step by step.
Okay, so I think the most important thing is OS, but for TalentTop, that's the first study. I think it will have such kind of is a step forward to use a neoadjuvant therapy for the surgery. We haven't seen the OS yet, but I do think because the primary goal is not for the OS. So if we want to have a solid evidence, maybe we should have international and larger scale randomized clinical trial to try everyone in the world which has OS. As Maria said, from Spain, we should work together, not just patient from China. That's for TalentTop, but at least it's a very brave step forward because that gives a chance for our patient first, patient center. And for the TalentTaste, of course, another one. And tried, and of the taste plus systemic therapy. We don't know yet because the OS is not yet clear. Maybe we'll have to wait. And for the TalentChoose, also, it's an option. But from the bottom of my heart, I believe this neoadjuvant therapy and plus adjuvant therapy and really can increase the OS. For example, I will talk about tomorrow because in my center, compared to 10 years ago, and the perioperative use of such kind of medicine increased from less than 10% to now 35%. And the OS, compared to 10 years ago, 5-year OS increased from 45, for all the patients received greater resection, the 5-year OS increased from 45 to 61%. That is 10,000 patients in my center. So I do believe, anyway, this trial deserves try because we can, at least some patient can benefit from that. Smaller, and we can give the best thing for our patient.
So very good. Finally, we come to the end. What I want to add is, to me, one of the point about the MDT is that when we have so many trial results, different studies, sometimes not all MDT members they are aware of the update. And therefore, an important component of MDT is to give an update, right, apart from discussion of the individual patient histories and treatment. But anyhow, this marks the progress for what we have made. And of course, we hope this progress will be transformed into the survival benefit of our patients.